So let me introduce myself. I am a family nurse practitioner. I currently hold a master's degree from Tennessee Tech University. All of my schooling, I am a true Tennessee scholar. That means that I graduated high school in Tennessee. I went through Motlow and got my associate's degree in nursing. Then I went back and got my bachelor's through Cumberland University. And then graduated with my master's from Tennessee Tech. Currently, I am enrolled at Vanderbilt University for my doctorate in nursing practice. And I am also working towards my nursing education postmaster certificate so I can eventually teach more often to nursing students and places and whatnot. So today we're going to talk about bone health. What do we know about bones? Just throw it out there. What do we know about bones?
They break.
Yes, they break. Yes, friend, they do. So you have to have bones in order for you to live. It's kind of like a heart. You have to have a heart in order for you to live. So the structures that we're talking about, this is going to be an overview of what the skeletal system is or what bones are. And then we're going to dive deep into what actually makes bones and all those things. But then we're going to get very granular in terms of why do we get softening bones? Why do we have fractures? Why do our knees hurt sometimes whenever we have chronic arthritis? And so we're going to talk about all of those things. And then we're going to go out a little bit after we have been granular. We're going to talk about how do we treat these things? What can we do to prevent it? And I know that I'm talking to mostly seniors, 65 and up. So some of this is going to be like, that's way past my age group. But no worries, I'm glad you said that. You can take this information and share it with your daughters and sisters and nieces and your granddaughters. So this applies to everyone, okay? So we're gonna talk about bone physiology and normal aging. We're gonna talk about the common bone diseases like osteoporosis. We're gonna talk about hormones. We're gonna talk about menopause. And then we're going to talk about testosterone, okay? And then we're going to talk about diagnosis and the risk assessments. This is probably going to be a little more dense than what you need, but I'm going to give you just an overview of that. And then we're going to go into treatment and prevention strategies, okay? All right, so this is where we get very granular, okay? So just go with me, take what you need, leave the rest, okay? Okay, so osteoclast. Right there, these are the bone cells, okay? Osteoclasts, they help build new bone, okay? They are stimulated by estrogen and testosterone. And this PTH is the parathyroid hormones, and then it helps with mechanical loading, and I'm gonna explain that here later. Osteoclast is, they reabsorb or break down the old bone that we have. Activity increases after menopause and androgen decline, and we're going to talk about this. We're really going to talk about this, okay? And then the other thing are osteocytes. These are the mature cells embedded in the bone. They act as mechanosensors or mechanical sensors, and they regulate the remodeling signal. So I'm going to explain this over here. It's nice and pretty. So osteoblast is actually the activation. These are the precursors, and they're recruited to resorption in a special site. So that means that if you need remodeling, we need to make more bone. These are the ones that get activated, okay? The resorption is the osteoclast. They actually dissolve old bone. So every 2 weeks, you're having old bone that is being broken down by the osteoclast, okay? And then the reversal is when the osteoclast, they basically send a signal to say, hey, you need to go to the knee and you need to remake this bone because we just had surgery and now we need to start rebuilding where it was cut or it was where the surgery went to. And then the formation is the osteoblast, which is this guys. They lay down the foundation for the new mineralization of bone. So we're gonna talk about that. A little note though is that bone completes one full remodeling cycle every 3 to 6 months. Okay, so with age, this formation lags behind where the resorption, which is this right here, causing bone loss. Okay, so we're gonna break this down. I'm gonna explain this in just a second. So yes, your bones are actually every 3 to 6 months you're making new bone. The signal is sent, so they say, oh, okay, let's go in there, let's break it down. This is what the osteoclasts do. And then the signal goes out, and then we begin to make new bone. So in other words, the bones that you had at 20 are not the bones that you have at 65, because they have remodeled throughout your life. And that whole process is about 3 to 6 months. Okay? So this is very important, and I'm gonna take my time with this slide because we as providers do let me just say it the professional way. It is an area of growth for us because we don't explain this to our ladies and to our men, okay? So 40% of women over the age of 50 sustained an osteoporotic bone fracture, and I'm gonna explain that, okay? Whereas 13% of men over the age of 50 experience a hip fracture in a lifetime. So women are 3 times more prone to have a hip fracture, okay? And then 1 to 2% have their annual, it's a 1 to 2% annual bone density loss per year after the age of 50, okay? So put a pin on that because I'm gonna show you how this affects you, okay? So this is right here, 1 to 2% of your bones suffer at 1 to 2% after the age of 50. And then 3 to 5% is the accelerated annual loss in early menopause. So that will be those of us girls that had a hysterectomy in our 30s, or in our early 40s, or that's considered an early postmenopause. And whether it is by hysterectomy or whether it is that's just how your mom and dad did it, and so then you went early for whatever reason, this is what we're talking about. Okay, we're gonna get more deeper in like the women's health aspect of this because I think it matters. It's very important. So the age-related physiological changes that drive bone loss is right here. Decreased sex hormone production, that will be our estrogen for the ladies and the testosterone for the man. Decreased calcium absorption in the gut, so this will be, and we're gonna talk about this because it's more than just you don't eat enough calcium. It's more than that. Decrease vitamin D synthesis in the skin. That means if you're not out in the sun, you know, but then you get into the whole, well, we don't want to get, you know, skin cancer, so can you go outside kind of thing. Or those of us that have a little extra melanin, we have a lot more trouble processing vitamin D from the sun. So people of brown descent, which is about 98% of the world, we have issues with vitamin D synthesis or breaking down and absorption of vitamin D from the sun. And this is that parathyroid hormone. When it's elevated, it increases that bone resorption, which is that breakdown, right? It doesn't make it thick again. Decreased physical activity and muscle mass. And then some inflammatory cytokines, and this is more into the, you know, you were born this way, or over time your immune system change, and some other stuff that we're not going to get into today. Osteoporosis. How many know what osteoporosis is? Yeah? Okay. I can tell you that the level of osteoporosis that we have right now in the US, it is so great. It's almost an epidemic. Okay? So the definition is a skeletal disorder okay, that is characterized by the compromised bone strength, which is the density or the thickness, and then the quality, right? Leading to an increased fracture risk. So remember how I told you to remember about the hip fractures? This is one of the leading ways why you can get a hip fracture in women, okay? And so we diagnose it by doing a DEXA scan right here, and I brought this right here. We're gonna pass this around. I'm gonna have it here for those of you that wanna come see it. So there's a couple things with this. One is that when you have osteoporosis, the density of your bone is so small to non-existent. So let's say, I'm gonna go right here, and I know that you guys really can't see it, but I'll pass it around. This is a full bone right here. It's nice and thick, and it's full of goodness in there, right? But then if you continue to look down at the bottom, it's very hollow. It doesn't have as much goodness in there. Therefore, the bone density is very thin, right? So if this is fullness, this is osteoporosis. That means that you went from full density to less than we call it 2.5 standard deviations of that density. It's a fancy way of saying you have fullness, now you only have about 25%. Okay, so that's why people that have osteoporosis, they tend to have more fractures. Okay, now, so the risk factors are these, ladies. You ready? Here we go, and I think we have some males here, so let's listen up. Age 65 and greater for females and 70 for male, and that is because males naturally have stronger bones, right? That's what makes them. So, but for us ladies, because we're dainty, we start at 65, and I don't quite agree with this. They actually just came out with a new study. It actually starts a little old earlier, and I'm gonna make that make sense here in just a second. So the female sex, so if you're a female, if you're postmenopausal, if you have low body weight, meaning less than about 20% or a BMI of 20. So who remembers the whole shake and bake back in the 80s? All right. Who remembers the whole skinny does it? You know, you gotta be skinny because that's how we wanna be. And we wanna be thin because that is cute and pretty. No, it's not. It's breaking your bones. Stop it. Okay. So the whole thought pattern that we had is it needs to change, because it has been instilled in us that if you're a specific size, a specific dress size, a specific pant size, then you look healthy. And what that has done is that we're automatically kind of falling into that category, okay? Family history of hip fracture, that's a big one. So this is one of those things that I need you to write down. Ask your brothers, ask your sisters, ask your whatever, your family members. If they have a history of a fracture, so like if your mom had a history of hip fracture, then you're gonna have most likely the percentage of you having a hip fracture is a lot greater than someone that doesn't, okay? Previous fragility fracture, let me talk about this, okay? This is when I tell you this is for everybody. So say you have a 22-year-old granddaughter that she decided that she was gonna go on a hike. And in her hike, she happens to step on a branch, she flipped over and broke her foot. Do you think it's normal for a 22-year-old to break her or fracture her foot? No. Why not? She should have stronger bones. Exactly. So if you had a fracture in your younger years, especially before perimenopause, you're a higher risk of developing osteoporosis. Okay? This is one of those things that is actually right now a call to action to all primary care providers. if you have a patient that is in their 20s, really in their teens, 20s, and really early 30s, if they have a fracture, guess what? We gotta do a bone density scan because now I need to find out where is your T-score. And so what we're finding out is that a lot of these children, they already are developing osteopenia, which is, soft bone softening, and we're gonna talk about that here in just a second. So this is very important, okay? So if you have sisters, cousins, all the ladies, man, not so much for y'all, but really for the ladies, if that is happening, you need to talk to them about, hey, I don't know how your provider feels about this, but maybe do you want to do like a bone density scan and see what's happening, right? Not everybody is on board with this new thought pattern, this call to action, but you can make a difference, ladies. You're the matriarchs of the family, so, what you say go, basically. Smoking and excessive alcohol. I'm not gonna look, but if you smoke and you vape, this is an automatic. You're gonna have a fracture and you're gonna end up with osteoporosis. No bones about it. Does that make sense?
Yes.
Because smoking decreases the amount of oxygen that your bones get. Okay? And without oxygen, we can't live. That's why plants give us oxygen and the good Lord in the air and all the things. This one is big one right here. Long-term glucocorticoid therapy in chronic diseases like rheumatoid arthritis, chronic kidney disease, and celiac disease. So let's break this down just a tad, okay? Long-term glucocorticoid is whether you have, say you have COPD, you have trouble breathing, or you have asthma, or you have a lot of psoriasis, or you have anything that is inflammatory that it requires for you to go to the doctor and say, Doc, give me one of them steroid shots. Okay? I have those patients. That's what they want every time they come in. Emma doesn't practice like that. I don't do that because I'm looking at your age group, I'm looking at where you are, and I'm considering your risk factors. Does that make sense? So sometimes in practice, we have to say, nope, you're not getting a steroid shot today. It's not indicated. And just think, okay, well, my hip likes it. My lungs hate it, but my hip likes it. So it's kind of one of those things that it really goes back to the provider on being aware of your symptoms and if it's truly indicated, or do we just want to make you happy because we want you to come back. Does that make sense? So that's one of the things. Now, there's some folks out there, they cannot help this, okay? So don't get me wrong. They can't help it. They have to have their steroids to be able to live, but that is like the extreme, right? So somebody that has rheumatoid arthritis is because their bones are already getting deformed, they're demineralized, and it's an autoimmune process. And then kidney, we're gonna talk about the kidneys here in just a minute, so I'm gonna skip that one. And then celiac disease, because of how it works in the gut, it does not allow for vitamin and minerals to really be absorbed. Okay. And then the common fracture size, look, it's like I knew what I was talking about. There's the hip fracture right there. Is the most serious fracture. If you have a hip fracture, your mortality rate goes sky high in the first year. Okay. So this is the little ladies, my girls, that they're like, oh, I just got out of the hospital. They said that I had a hip fracture. So then my mind goes in overdrive because I'm like, oh my God. How did we get here? It's long term. Any of these that I'm talking about is never short term. This is not an acute setting. This is long term, right? Because we start from early childhood and then we kind of go up to, 60s, 70s, 80s, and 90s. The vertebral spine, thank you, thank you, is the most often and is asymptomatic. Does anybody knows what asymptomatic means?
That means that you don't have any symptoms.
No symptoms, very good. This is a problem Because if you already have osteoporosis and you go to your mom's house or your sister's house and they're like, my back hurts. It started a couple days ago and it's just kind of not going away. Or they used to stand up and then all of a sudden they're kind of doing this. Happens a lot. And they don't feel it, right? Because they just think it's just another pain. So they're not associating that the pain that you're having now is because you probably fracture a rib or something. Vertebrae, okay? And then the distal radius, the early one, for most women, and I actually do this in my practice, that is the first warning sign for a lot of us providers to say, ooh, maybe we should do an, off-schedule DEXA scan, this one right here, to see the density of your bones. Okay, so this distal radius, it will be right here. Okay, so that will be like a wrist fracture. You were down in the garden and then you went to stand up and then you kind of fell and then your wrist broke. Okay. Or you're making all those cookies that you're bringing me to the clinic. Just kidding. All right. So for a lot of people, this is an early warning. Okay. And then the humerus, which is the upper arm, that's, when I fell and I broke my shoulder bone. When people say that, that's what we're talking about. And this one decreases a lot of disability because once you break it, guess what happens? You're having trouble raising it. You're not able to reach. You're not able to do the, or whatever boogie thing you do. So this is why knowing this is a call to action to providers right now in the U.S. because this is not good, ladies and gentlemen. This is not good, okay? And these are the classifications. I'm not gonna go into this, but if you wanna ask me later, I can explain them. But this is osteomalacia. We're gonna talk about osteomalacia here in just a little bit. It's basically when the weakened bone density, and then we tend to see in the larger bones because they're demineralized, okay? So minerals are not in there. So these folks kind of tend to waddle when they walk, or they look like they have bowed legs. We tend to see that. Osteoporosis, you can see where we went from normal to kind of changing a little bit, and then changing a lot, and then changing a lot, okay? And this, by the time you get here, I can assure you she's had multiple fractures. And so because the bone doesn't heal, what do we do when somebody fractures a bone? We cast it so that it can, heal again the proper way. Well, when this is happening, what are you going to do? So this is kind of why if you see some of these, people, especially a lot older, we tend to see a lot of this. So they kind of walk like this. Yeah. That's kind of what we tend to see. And then Paget's disease, this one we're going to talk about. Sometimes as a provider, it's hard for me to tell my patients, oh, it looks like you have Paget's disease. And then it's like, oh my God, I have a disease. What do you mean I have a disease? It's just a fancy way of saying that because your bones are demineralized, they actually, so you've noticed some people have like a larger knee on the right side than they do on the left side. That is this right here. Okay, so it's from like recurrent wear and tear, especially people that have had like surgeries in the knee or replacement. And so we kind of tend to see a lot of this. You can also have it in your lower legs. So in the ankles, you have a much, larger ankle than you do one or the other. It's typically not, and right now, let me say this though, Paget's disease in this situation, we're just talking about bones. You can have Paget's disease where your bones, basically your bone just kind of get enlarged and abnormally enlarged. So you'll have like a thicker, more prominent jawline or a thicker, more prominent forehead. There is Paget disease of the breast and the nipple. So we're not talking about that. We're talking just strictly bones, okay? All right, here we go. So these are the other common things that we tend to see in older adults. Is osteomalacia. That's basically when bone mineralization is lacking due to vitamin D. or calcium deficiency. Okay, so you have bone pain, muscle weakness, and kind of that waddling gait. That's what I was talking about. All right. Your labs, this is why your labs are important, because if your vitamin D is low and the doctor says, I think you need to take more vitamin D, say, yes, sir, thank you, I'll eat it with a strawberry. And then the alkaline phosphatase, and then just the phosphate. The alkaline phosphatase is elevated and the phosphate is low. This is a little much for y'all, but just understand your labs matter, okay? This is different from osteoporosis because the bone formed but not properly mineralized, right? So the minerals are not in there and getting absorbed. Whereas Paget's disease is the disoriented bone remodeling, meaning like it's excessive. The breakdown is followed by, it's basically just disorganized regrowth. So then you'll have the thick knee or the thick ankle and those sorts of things. It primarily often in the skull, the pelvis, the spine, the femur, but really the femur is what it is at the end, but it looks like it's your knee. Okay, so it's not necessarily the patella, it's the femur attaching to the patellar space. And then we have osteonecrosis. This is basically just bone health due to loss of blood supply. And we typically see that in the femoral head, and that will be right here. So this is a hip right here. So this is the femoral head right there. And the humeral head, so that will be up here, your shoulder, and then your knees as well. This is one of those where the corticosteroid, alcohol, some trauma, and then sometimes you present with joint pain, but the MRI is the gold standard. Okay, so the gold standard will tell you if your bone is dead. Obviously, you will know because it will be in pain, it'll be black, you can feel it, you can walk. And then bone metastasis, this is typically due to cancers, okay? But they come from, and this is where I want you to pay attention, it typically spreads to bone, bone, breast, prostate, lung, kidney are the most common, okay? And the metastasis can cause fractures, elevated calcium, very severe pain, spinal cord gets compressed sometimes, but the bone pain in older adults, you know, it warrants imaging and workup. So this will be when we already have established that there is cancer present, okay? So it's not like you're gonna wake up tomorrow and you have joint pain, you don't have a history of cancer. I don't want you to say, well, Emma said that you need to check me for bone metastasis. That's not what I'm saying. Okay, all right. Make sure that we get that one. Okay, here we go. Menopause. Okay, so how estrogen protects the bones. So it inhibits osteoclast formation and promotes osteoclast apoptosis, which is meaning like absorption and reaction. It reduces the resorption, which is the breakdown. So it basically helps with bone formation, okay? Estrogen stimulates the osteoblast activity and the differentiation in the estrogen receptor A. Scratch all of that. Let me tell you what that means. That means that the estrogen that you have in your bodies from your ovaries, okay, is also the same estrogen receptors in your joints, in your bones. Just know that estrogen receptors are in your brain, in your heart, in your bones, okay? So this is why in perimenopause, let me skip this just a little bit here. In perimenopause, so whenever you're feeling like the hot flashes and I'm going crazy and my thoughts are foggy and I can't remember, one day I love my husband and the next day I want to, and so it's all part of it, right? But guess what? You're still having your cycles every month. And sometimes the cycles are normal, sometimes they're longer, sometimes they're irregular, sometimes it's a faucet, sometimes it's a desert, all the things, right? That's perimenopause, okay? But then in early postmenopause, 3 to 5% loss a year is beginning to be accelerated because your estrogen is decreasing, so you're not having the osteoclast working in there saying, hey, let's make more bone and have bone regeneration every 3 to 6 months. Does that make sense? Then late menopause will be, you have already went through menopause and, you know, you're still having some 1 to 2% loss a year. But then it kind of slows down a little bit, it seems, right? But then by the time you're 70 or 70 plus, you have had a cumulative of 30 to 40% total bone loss. But just know this, from the minute that perimenopause is beginning to hit, you're already having bone loss, okay? So that's what we're trying to say with the estrogen. So when we don't have enough calcium in our diet and you're postmenopausal, guess what's happening? These numbers increase tremendously. Does that make sense? But estrogen is already not present here, right? So then think about it. If you're not, if you're not eating it and you're not able to absorb it, then this loss increases even more by the time you get to 70. Okay. All right. Now, this is hormone replacement therapy and female bone health. This is the reason why I chose this, because I wasn't sure if I was going to have males or females here, but I know that just based on my first visit, we had a lot more females here. Okay, so I'm sorry that you're kind of left out there, but learn it for your mom, sister, brother, cousin, anybody. Okay, this is where we're going, okay? The benefits of HRT or hormone replacement therapy, that's what that is, HRT, for the bone, is that it reduces the fracture risk by 25 to 35%, okay? It prevents postmenopausal bone loss when initiated early. And this early, I just got back from Harvard. I went there in March and I did a whole women's health, hormone therapy, and menopause learning module there. It was like a mini internship with them. And I learned so much, like it instilled a fire in me about we're doing a disservice to our ladies. Okay, so when initiated early, that means that they're saying within the first 10 years of you going through menopause, you should be receiving HRT, right? Whereas before it was, we don't do hormone replacement, it's bad for you, it causes cancer. Anyway, bring me back later or let's talk about it. That whole has been debunked, okay? And I have plenty of studies that you guys can use and read if you want to get that information. The FDA approved for prevention, not just treatment, of osteoporosis. Well, what do you know? That is new, that just came out because of a big initiative that was pushed last year by several GYN providers that manage menopause. In fact, 3 of those providers taught at my course that I took in the spring. And they were in office with Secretary Kennedy. And so they help reverse the black box warning on estrogen and estrogen replacement. Most effective in the window of opportunity, that will be the 10 years before the age of 60. Does that mean that if you're over 60, you cannot have hormone replacement therapy? The guidelines are saying that nobody's too young. Nobody's too old to initiate therapy. So this is why I wanted to talk to you all, because I want you to talk to your providers about this. Say, hey, do you know that they have changed the guidelines for all of this? How do you feel with my age group and my family history and my personal history? Now, this does not apply to everyone, because I know that over the age of 65, most women and people in general have a lot of disease processes, and now we have some, other issues that we have, heart attacks and strokes and all the things. So talk to your provider. My goal to teach you today is not for you to learn all of this, is to let you know, be empowered to talk to your providers and advocate for your health, because sometimes there's room for growth. Okay, all right. The risk and considerations with hormone replacement, it says it'll slightly risk the breast cancer. We haven't proven that yet. Otherwise, when combined with estrogen and progesterone, not estrogen only. Typically, if you get some hormone replacement for women, if you have a uterus, okay, if you still have a uterus, don't ever let anybody just prescribe you estrogen and not prescribe you to progesterone, okay? Estrogen and progesterone always go together if you have a uterus, okay? There was thought process about increased thromboembolism. This is with the oral. So there's several ways that you can get hormone replacement. I'm not going to get into all of them, but just think, if you take a pill for the hormone replacement, it's going to increase your risk. Transdermal is the better way to do it. Okay, and transdermal can be a gel, it can be a cream, it can be a patch. Benefits versus risk must be individualized. Okay, that means if your sister to your right, was able to get him and you don't get him, don't get your feelings hurt. Okay. So this is part of what it used to be, and the reason I kind of left some of this like this, because I want you to understand this is where we were in terms of teaching, but all of these have changed. It used to be the lowest effective dose for the shortest duration. What is the shortest duration? What does that look like? So this is not the case anymore. It's really individualized, right? Okay. Selective estrogen modulators. This will be the raloxifene. It acts like estrogen or on bone, but it blocks breast and uterine effects. So this is what they used to tell ladies, oh, just take this raloxifene and you're gonna feel fine. Didn't do nothing. You're still having, hot flushes and losing your mind and all the things. So, but it does reduces the vertebral fracture risk. The way that raloxifene works is that if you've had breast cancer before, this will be your option. Okay. And it's approved both for prevention and treatment of postmenopausal osteoporosis. And then it reduces the risk of invasive breast cancer. Okay. Testosterone, yay, we finally get there. So testosterone works very similar to how estrogen works, and so it binds to the androgen receptors on the osteoblasts and it stimulates that bone formation. It indirectly is converted, indirectly converted to estradiol via the aromatase estrogen. Estrogen is actually the dominant protector of male bone. So what it's trying to say is that, men have testosterone, and through a process of science, it turns into estrogen, and that secondary process of the estrogen is what actually helps. Okay. So it stimulates bone expansion. Therefore, men have larger, thicker bones due to the androgen action, and duration grows. So let me say this, just a little thing on males is that if you have husband, brother, son, cousin, whoever, and they're like, man, I'm tired. Man, I don't want to have sex anymore. Or any other, this is not normal for you. You just come from work and you just sluggish on the couch and you just want to watch TV. You don't want to wash, mow the lawn or all these other things. Have their testosterone checked. You'd be surprised. Okay. So because of that, decrease in testosterone, and I see patients, as early in their, 30s asking for testosterone replacement because they don't feel well. But there are issues there, right? So everything in context with age, appropriateness of treatment, and long-term effects, right? So this matters because if I have a young teenager who's supposed to have nice, big, strong bones, all of a sudden getting fractures all the time, then I'm going to be very worried. There's something wrong with that child. Does that make sense? Same thing in your 20s and early 30s. And then we talked about this. It supports muscle mass and strength, just because that's how men were made. Reduces the fall risk, and it protects the bone indirectly. And we talked about that because it converts into estradiol. And then low testosterone correlates with decreased bone mass density. It increases the fracture risk and hip fracture mortality in men. This is big because if a man gets a hip fracture, huge deal. Ladies, it's almost like, she broke her hip. Does that make sense? But for men, for them to break a hip, that's big, y'all. That's really big. Okay. Now, here we go. 20% of men are underdiagnosed of osteoporosis just because the focus has been on women with the estrogen. The andropause is whenever that testosterone, see right there, it begins to fall after the age of 30, but it really gets low after the age of 70. Okay. Hip fracture, same thing, have 2 times higher mortality from a hip fracture because this is not normal. Okay. Androgen deprivation therapy, so like patients that have had prostate cancer, big deal for them. And it causes rapid bone loss. So if you have a family member that has had a history of prostate cancer, check on them, they're not okay. All right. And then secondary causes would be for osteoporosis in men, has a secondary cause is hypogonadism, steroids, alcohol. So if they don't eat well, they eat trashy, pizza, beer, any other alcohol. Hypogonadism will be like where their testosterone is just kind of low, you know, but it can cause it, okay? Now, diagnosis and risk assessments, we're almost done, y'all, promise. DEXA scan, we talked about that a little bit. Screening in women, the 65, that really, I check my patients at the age of 50. I will say 60 or 65 for men. And then it's low radiation. You do it every 1 to 2 years. I think it's every other year is typically the guidelines. But then you can also like break out of the regular normatory. If it's somebody younger, you just kind of do it out of the normal protocol. Okay. And then the we call it the frac stool is what we normally call it. And basically just tells us a 10-year fracture probability. So we'll ask you questions, and these are the questions that we want. We want your age, your sex. So if you're a female, just know it's already at a point. Prior fracture, history of family members having fracture, smoking. We talked about steroids, rheumatoid arthritis, osteoporosis, alcohol, all the things. So the laboratory workup, this is a little much for y'all, but just know, get your labs checked. We want to check your calcium. We want to check your parathyroid. We want to check your CBC, complete blood cell panel, your thyroid. And men, we want to check their testosterone. Okay. Get that vitamin D checked. Okay. And then creatinine is typically checking and some other things. And then you don't know this. You don't need that. That's extra. Okay. This is fun. So let's talk about medications for osteoporosis. You ready? So we have several. So some work like bisphosphonates. This will be your like your alendronate, ibandronate, depending on where you fall on there, and it's the first line therapy. Okay, it's weekly or monthly. So some of these you can actually do as an infusion. My favorite to start patient on is alendronate. Okay, the higher you get into these numbers over here, the risedronate, the cylindroic acid, and the ibandronate, these ones right here cause a lot of symptoms and they cost a lot of money. So just stick with this one. Okay, alendronate, Medicare will pay for that one. So this is my first line therapy when I'm treating my patients. Okay. Then this one, it reduces 50% of vertebral to 30 to 40% in hip fractures. Okay, this is the reason why we like this, guys, over here. And it's an antibody, actually, so it actually works in the immune system, and it prevents that osteoclast that causes the breakdown. It just prevents the formation. Okay, this is an injection that you get every 6 months or so. And it's much better though. It decreases the 68% in osteoporosis, vertebral 40%, and then hip fracture, okay? It is very useful because this alendronate, the way it works, it beats your kidneys pretty good. So if you're not a candidate for any of these bisphosphonates, then you can do the denosumab or the Prolia. So patients that have like renal insufficiency, if you have chronic kidney disease, all of those things. But the thing is that if you discontinue it, say you get it every 6 months, and then you're like on year 2 and you're like, I don't want to get this after I get it, because you will have some side effects from it, joint and bone pain, generalized body aches, headaches, nausea. So if you're like, you know what, not going to take it, second year, guess what's going to happen? You're going to have a rebound bone loss. Okay, so if you want to change it, you need to talk to your provider about transitioning over. Okay, this one over here is the teriparatide or slash abaloparamide. It stimulates the osteoblast activity and new bone formation. Okay, so my patients that actually have just like the slowing down or the bone density that is beginning to decrease, the osteopenia, I really start them on here, alendronate, and it's actually a good preventer, okay, for turning into osteoporosis. So my bones are just soft, but not quite osteoporotic. I'm gonna prescribe the alendronate, okay. This one down here is kind of similar, but it also helps with bone formation after you have had the actual diagnosis of osteoporosis. Does that make sense? So you can take this one here before osteoporosis and with osteoporosis. This one here, you take it after you've had osteoporosis, okay? And this one is really reserved for severe osteoporosis or treatment failure. And treatment failure is considered after 24 months, okay? And then the Evenity, this is the newest and the greatest and the bestest and the most expensive and most expensive. Doesn't get covered by insurance. I think, actually, you know what? I think that if you look up like Trump RX, because they actually do have some name brand medication on there. I think it's on there. I'm pretty sure it's on there. And so this one is once a year. That's the why people love it, because it's once a year. It's the newest class, it's the funnest and the greatest and the new kid on the block, and it's very expensive. Insurance don't want to pay for it. But it has proven in the frame trial that it decreases vertebral fractures by 73%. Okay. All right, non-pharmacologic treatments. This is what you and I can do every day. If you want to take a picture of this, you can. But calcium, here it is. We want about 1,000 milligrams per day in men, but really 1,200. Just know 1,200. Okay. So food sources such as dairy, leafy greens, fortified foods. You can do calcium carbonate with food or calcium citrate. Don't do calcium citrate. This thing right here, listen, it will send you to the bathroom and you'll wonder why Emma told you to take that. You're gonna hate me, okay? This is a good colon cleanse. You don't want that one. So this one right here, when it says calcium carbonate, you know what that is? That's your Tums, girls. Those are Tums. Take you 2 Tums. That's all you need. Vitamin D, 65 and greater, it's about 800 to 1,000 IUs a day. But honestly, you can actually, so you can do it this 2 ways. You can actually just get it over the counter and just take the 1,000 IUs daily every day or every other day, and you should be pretty good. So it depends on where you are, where your, osteoporosis, where your osteopenia, or softening of your bones are. Okay. Now, deficiency in vitamin D is very common in older adults. Okay. Remember how I told you, look at your labs? This is why. because you already decrease your absorption, your ability to absorb vitamin D, okay? Exercise, weight bearing, walking, hiking, dancing. Hey, we can do a dance. Don't you still have a line dancing class? I think they should be like regular. I should attend to that one. I can be like an instructor. Just kidding, just kidding. Resistance training. These will be the ones that you kind of do like the resistance bands. You can do those. Tai Chi, actually, studies, sorry, I'm all about studies right now. This Tai Chi right here is actually one of the best ways for you to reduce fall risk, because it works your cores and it works your hips. And then fall prevention, you know, your medications, you know, don't take your sedatives at 9 o'clock in the morning when they really should be at nighttime, all those things. Home hazards, this is a big one. That's the reason why I left this one in here. Rugs, 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 rugs. Remove those rugs from your house, ladies. You don't need them, okay? If you buy house shoes, make sure that they have like the grippy bottom. So don't get the cute ones that you can go like this. Get the ones that have enough grip so that when you walk, you're not slipping and sliding, okay? Of course, your eyes. You know, this cracked me up, hip protectors for high-risk individuals. Like, you're gonna walk with like hip protectors to the store. Like, I don't know. This is not the 1800s. I don't know. Anyway. Anyway, we're not gonna go there. Ooh. Special considerations. This one right here, prednisone. How many of you got, actually don't raise your hand, to have taken prednisone because you got a cold? This is what I was talking about when I was talking about steroids earlier, okay? Chronic kidney disease and bone is because it causes the renal osteodystrophy, which basically just means that you have a decreased vitamin D activation, increased that parathyroid, which causes secondary hyperparathyroidism, which means that you just can't absorb calcium and vitamin D, okay? And we talked about these, biphosphonates, we talked about that. That will be your alendronate. When EGFR is less than 35, we don't add it. Prostate cancer, we talked about that. The androgen deprivation. Check on your guys if they have had prostate cancer. Seriously, they're not okay, all right? The screen baseline for ADT, we typically want to give the alendronaic acid for the guys right there. Or the Zyvega if there are any metastasis to bone, okay? And then drug-induced, this is a big one, okay? I love this one right here. If you don't hear anything else, focus on this one, okay? Agents causing bone loss includes PPIs. They reduce calcium absorption. Anything that you take for your acid. For gastric reflux, they decrease your, because it decreases everything in the stomach. You don't have any acid, and you have to have acid to be able to break down the calcium, okay? And then anybody that takes anti-epileptics, so seizures for seizures, they decrease vitamin D. SSRIs, these are your selective serotonin inhibitors. So they will be your citalopram, they will be your Prozac, things like that. Celexa, okay? And then TCD, this one is actually, we typically give this for patients that have high blood pressure, or we use it in, whenever we want to reduce the blood pressure in the fluids. It's almost like a diuretic, okay? Loop diuretics, there's another one, so that will be your Lasix, your furosemide, okay? And then always review your medications with your doctors just to make sure and see where you are. Especially if you already have a history of osteopenia or osteoporosis, have them go and look through your meds. Which ones go, which ones stay. Okay, so bone loss is a natural but preventable consequence of aging. Okay, early intervention is the most important thing. Women lose rapidly within the first 5 to 7 years after menopause. Okay, so we have to try to get you on estrogen. Men severely underscreen. Get them to the doctor. Get them, evaluated. Check their labs. Check their DEXA scan. Okay, there you go. DEXA scanning and FRAX risk assessments should help guide the treatment, especially when we're looking at a 10-year This is a 10-year overview, okay? And then biophosphonates, really, it's just the first line therapy. It's cheap. So think about this biophosphonates as the good old steady boyfriend, okay? He's good to you. He gets up in the morning. He goes to work. He brings you flowers. He takes you out to eat every now and then. Y'all take a trip twice a year. That type of boyfriend, okay? So they're very dependable and they're cheap. So take those if you can. Obviously, if that's not an option, talk to your doctor and see what other options you got. Remember, the newest one is always going to be the most expensive, okay? And then calcium, vitamin D, weight-bearing exercises and things. But out of all of this, you know what's going to help you the most? Hormone replacement and biophosphonates, okay? So depending on where, I'm assuming, I shouldn't assume, but I will imagine with a group this size, we probably have gone through menopause, right? In our 50s, late 40s, whatnot. So ask your provider, is it appropriate for me to have estrogen replacement? You know, the new studies are out. Tell them, new studies are out. Have you read those? I'll send you those studies so that you can have them. Because a lot of us are practicing the old way. And so we're doing that disservice to our current, you know, population. So bone health is everyone's concern. Screen, prevent, and treat. That was so nice. Sounds good? All right. Now, any other questions? We're good? All right. Thank you all so much. We appreciate it.